Hello, and welcome to another Think Thrombosis podcast from medthority.com. My name is Dr. Geoffrey Barnes. I'm at the University of Michigan, and today I am excited to have a wonderful colleague and good friend, Dr. Rohan Khera, join us. He's an assistant professor of medicine and cardiovascular medicine at the Yale School of Medicine. He's also the director of the Cardiovascular Data Science Lab and an associate editor for artificial intelligence and digital health at JAMA. Rohan, thanks for being here with us today.
Thanks, Jeff, for having me here.
You know, there is so much talk in the lay press and even in the medical media and conversations around artificial intelligence and how it's going to transform everything in our lives. I'm wondering if you could start us off by just giving a very brief primer. When we hear people talk about artificial intelligence and how it applies to medicine, what is it we're talking about? What should we be thinking of when we hear this term artificial intelligence?
Jeff, I think, it's certainly one area that's like really grown in medicine across domains. And the key thing that we've always done in medicine is we've thought about risk and we've thought about how to measure that risk and improve patients' outcomes. And we've used statistical models and tools to do that before. But as our data have grown more complex, we have included language as a component that goes in our electronic health records, imaging, diagnostic tests. The simple statistical models are unable to handle these kind of data. So we developed a new domain of learning called machine learning, where these data can be effectively handled. What has happened beyond that point is now we have built tools that models can actually learn iteratively from these data and learn about risks and outcomes. And that is where the domain of artificial intelligence comes in, where the machine learns from existing data, adaptively improves its learning as it gets more input. And that can actually result in improving how we can infer information and then use it for patient care.
That's really amazing. So you have these big complex data sets. We've used these more advanced analytic tools, but now it's just more than running one model. It's actually learning and really improving on itself. How have you seen this applied in medicine? What have been some success stories that you could point to?
I think some of them are very obvious, like imaging, I would say, is one domain where we have seen a lot of applications, starting from anything from chest x-rays to echocardiography to cardiac MRI, and in other domains of imaging as well, where, a two-dimensional photo or a three-dimensional video of sorts is able to be inferred explicitly for identifying things that we needed radiologists or experts to read. What's been really remarkable is not only are we picking up features that clinicians could see, but because these models are so rich in extraction of features or elements of the image, they're able to find patterns and that we couldn't see as humans in these images itself. So I think that's been fascinating, in imaging. And I think specifically in cardiology, electrocardiography or ECGs, we've been interpreting them for over 100 years, but now we're picking up features that require cardiac imaging from these simple ECGs. So I think those have been very remarkable successes.
Well, I'm glad you brought up the electrocardiogram, because as we think about atrial fibrillation, I'm wondering, where do you see maybe an unmet need in the way atrial fibrillation is currently being diagnosed and managed? And how could AI perhaps help to fill that need?
I think AFib is one area that is very primed for disruption by AI, especially its diagnostic care. At the bare minimum, it's people who have known atrial fibrillation. We have to be able to scour our health records to be able to identify them. And that merely means the application of large language models or natural language processing to extract mentions of that from our electronic health records and making sure the physicians or clinicians know that diagnosis exists and is appropriately cared for. That's the bare minimum. But I think what we can do more of is among people who are high risk, especially those who have had thromboembolic events, those who have had a stroke. We currently rely on a spot diagnosis of atrial fibrillation that as a rhythm that goes in and out, people may not know if somebody has it or not. So we're finding these new algorithms that take any electrocardiogram and are able to pick up people who may have atrial fibrillation even when they don't have it at that very moment. So that risk identification, I think, is one area where we can really identify people who have atrial fibrillation but are not manifesting it with that rhythm at that very moment.
So are you talking about maybe features on an EKG that aren't diagnostic of AFib, but suggest that there could be a high risk of AFib that's happened in the recent past or may come up in the future? Is that the kind of thing that these tools do?
Absolutely. Because, I think as clinicians, we know that left atrial myopathy or other muscle disorders, they correlate very closely with atrial fibrillation risk, but we have to rely on cardiac imaging to even get to them. But it's of course very conceivable that these features are electrically present. It's just that we haven't been tuned enough to be able to pick them up effectively and consistently, which these models, because they're trained on such large volumes of data with so many examples and with consistent patterns they learn and to interpret, they're able to more consistently identify those high-risk features.
That's great because when we get those high quality EKGs, we might get it in the clinic or somebody might get it in the emergency department or something like that. I've often felt there's so much data there that I, as an individual, don't necessarily know how to interpret. And it sounds like these models can help me. But it also strikes me that that's a very small snapshot in time, right? That's maybe 10 seconds of electrical data that I'm gathering. But many of us are wearing, wearables and watches and other devices that are capturing data all the time. Is there an AI application for identifying AFib or other cardiac conditions using some of that data?
Absolutely. And the devices we currently wear, they have two kinds of sensors that detect some sort of rhythm challenges. One is this PPG or photoplethysmography. And I use this technical term so folks can hear that the light that comes out that you might see on your wrist, it's picking up the pulsatility of the blood. It's not checking the electrical activity. But that pulsatility pattern has been the one that we use when you have irregular beat alerts. But many of these current devices are actually capturing one lead electrocardiograms, one lead ECGs. And whatever we're building on the 12 lead models can essentially be adapted for one lead ECGs. And people can get frequent testing at home. And I feel that really opens up an opportunity to go beyond that 10-second snapshot in a health system to somewhere where people live and are doing their daily activities.
So as you reminded me, even from my days as a med student, that irregular rhythm, which is sort of pathognomonic or sort of drives you towards that AFib diagnosis, that's something that could be picked up with some of these wearable devices, but then can even go beyond that because you can get that one lead EKG, with your finger and wrist and all of that. And is that data reliable? I mean, do we have any evidence that this is really able to detect AFib in a meaningful way?
So for the actual diagnosis of AFib, there have been two large studies, and again, no major association with Apple or Fitbit, but both of those devices have actually done large studies, the Apple Heart Study and the Fitbit Heart Studies, which have actually shown the detection of AFib. Both of them are actually FDA cleared for detection of AFib on some of their existing like PPG algorithms, and their ECGs have been specifically shown to detect atrial fibrillation. But I think the ideas of the stuff we've talked about before, about using that ECG data to identify high risk features, that information is currently, I don't think, feasibly extracted from them yet.
Got it. So that's sort of exciting things to come in the future. Yes. We've talked a lot about the role that AI and these tools can have in helping to diagnose AFib. And we know that there's a huge unawareness, underdiagnosis, and undertreatment problem with AFib. Are there any applications that you're aware of, either currently in development or things that people are thinking about, to use AI to better treat AFib or other cardiovascular conditions?
Yeah, I mean, so we've been working actually in our group on ideas of, leveraging the idea that if you measure something, you're able to improve it. It's a corollary to a common dictum that you cannot improve what you cannot measure. Mm-hmm. So we're trying to measure how many people are inappropriately not receiving optimal antithrombotic therapy, for example. And for that purpose, we are actually deploying large language models, which are these new class of models that power ChatGPT, a very popular chatbot, and using that information to see whether we can extract clinicians mentioning atrial fibrillation, not describing features that would, preclude the use of anticoagulants, not prescribing patient preference against anticoagulation, but then still not prescribing them. So we're using some of those, I would say, core principles in quality measurement and improvement to really drive the care at the health system level. There is an increasing interest of patients directly interacting with their chart using similar chatbots and assessing whether they are getting optimal care for something or not. Again, all in development, but certainly, like, we will have a time when patients would know when they're not getting the therapy that they should get based on what are guideline recommended therapies for them.
Another application that I think could be really ripe for tools to help move us forward is in the appropriate treatment with stroke prevention therapies. I think about the number of patients who are not receiving anticoagulants or those who are receiving the wrong dose of their anticoagulant. And to date, most of our tools, our clinical decision support tools, have been very black and white, right? You get bombarded with a message, this patient's untreated, or you're on the wrong dose, but it may not always apply. And if we could make them smarter, more applicable, could we actually help clinicians and patients engage with these different clinical decision support tools and improve our stroke prevention therapies? I don't know if you've heard of this or thought about this at all.
No, absolutely. And I think, our biggest barrier for delivering optimal quality improvement initiatives in our health systems is the fact that many of the decision support tools are very crude. Like they pick up on very crude features, and it just contributes to alert fatigue, where people are alerted constantly about something which they know is not appropriate care for the patient. So I think some of the applications you mentioned just represent key extensions of the quality measurement work I was suggesting before, where we can actually see whether the appropriate therapy is being delivered not only at yes or no level, but at a much more granular, fine-grained level. But yes, the digital health record does allow this advance because we can have the dose, the prescribed dose, and so forth. I would say, like, we do have a challenge, though. We have a challenge in knowing when we start something. We don't have a way to monitor and keep people continue to take these medications? Are they filling at the appropriate time? So some of the innovations can be tracking whether the fill rates that people report are aligned with what they should be taking and so forth, which we haven't done at scale at all yet.
You can't talk about AI without thinking about these large language models that really everyone has access to on the internet now to, ask questions, get data, all of that. And I'm wondering, have we seen any benefits, any maybe potential concerns with how the public is using these to get medical information? I'm thinking about people searching to learn about AFib or to learn about drugs, and how are consumers using these publicly available tools?
I think that's an excellent question. So there are some, I would say, articles out there that describe in different domains how patients are directly interacting with, these chatbots like OpenAI's ChatGPT, and actually entering their information and trying to get information out on therapies. I think the quality of information is definitely variable. And most importantly, it's hard to know what each person is getting because each person gets their own different answer. And it's not like there's a standard set of rules. The way they frame their question determines how the chatbot will describe their answers. And over time, the actual model that underlies these public models also evolves. So people have said that it's largely reliable, but also because patients are so diverse and heterogeneous in their clinical profile, I think there's a huge risk of people getting bad advice about something because they didn't have the knowledge to really actively understand what was being suggested. So I do worry about it.
Yeah, and the little that I've played with them, each of these different LLMs that you use has a different way of providing answers back. Some are very long and narrative, others will include graphics. Honestly, many of them don't provide references or citations, places to go. So you could see how somebody who doesn't have medical training would read something and then not know what else to do with it. And so I do think we have to recognize that our patients are going to use these things. They're going to ask questions. We need to make sure it's giving good information, and we as clinicians are prepared to address their concerns. I don't know if you've had any experiences like that.
So we have actually some colleagues at Yale who have trained. Developed some, I would say, second order models that are trained on medical information and then are now using clinicians to validate response. So they are using strategies where clinicians would ask controversial questions or questions that are large, on the borderline of like whether I should stop this therapy, I just had a clot, or like something very challenging. And it would see the response in those edge cases and actually give feedback to the model. And so there are some colleagues here who are explicitly looking at the junction of where appropriate care may be now. We should use them effectively if we can. That's the entire point. But we should know where they fail.
Yeah, absolutely. Well, this has been such a fascinating conversation. As I think back, a couple points are really sticking out to me. You helped me really understand how machine learning has helped us better analyze these large, complex data sets, but that AI allows the tools to really learn and adapt as they're going through and improve the way in which they understand the data, and that we've had success in many areas. You mentioned, imaging, reading echoes, cardiac MRI, but in the AFib space, it's really been used primarily to date to help with diagnosis and identifying who's at risk, thinking about identifying left atrial myopathy from an EKG, or using data from a wearable to figure out who might have atrial fibrillation from their PPG data or a single lead ECG. And that we're sort of moving into this treatment phase, because if you can measure something, then you know what to treat. One example is developing a smarter type of a clinical decision support, whether it's clinician facing, patient facing, or both. But that also, we can't forget about these publicly facing large language models where, people can ask anything they want. And I loved your point that the way the question is framed is going to directly impact the answer that they get. And we have to understand people may not always know how to ask a question and how to interpret the answers they get back. So we need to work on how to support them and how to improve these models. Anything there that you would add or correct to what I summarized?
No, Jeff, that was perfect. Thank you.
Oh, well, Dr. Rohan Khera, thank you so much for joining us. And to all of our listeners on the Think Thrombosis podcast from med30.com, I look forward to seeing you on another installment.